of this separation. But in an older age, having lived together for 30 years, 40 years, or 50 years, at that time, if you are separated due to death or divorce, then definitely that leads to a lot of depression. Of course, lower socioeconomic status. Many people say that money cannot buy happiness, but within limits, yes, money can prevent you from depression. So lower socioeconomic status leads to more of depression. Then, of course, comorbid general medical conditions that lead to a lot of restriction in life, a lot of restriction in their activities. So that leads when they are not able to come to terms with it. In fact, when I was presenting for some other conference, I came across an excellent term. 1 + 1 is not 2 in old age anymore. So it's synergy. Synergy is used in the positive terms, but here in old age, synergy is used in the negative term, in the sense that a diabetes and hypertension in a 30-year-old is 2 diseases alone. But when the same thing happens in older age, then it leads to much more problems. And urinary tract infection may be something very simple in a younger individual, whereas that may lead to sepsis and coma all of a sudden. Somebody who goes to sleep, morning you find him in coma. So that leads to, once they experience some difficulties, then that puts a lot of fear in them. So they start avoiding so many things and slowly isolating themselves, and also that leads to depression. Another thing is uncontrolled pain. If the pain is not managed properly, because in old age we are afraid of giving medications for pain, which can cause other complications, sometimes renal failure, and you cannot use it for a very long time. But this uncontrolled pain, in fact, there are a lot of people who have even attempted suicide because of this uncontrolled pain. Then insomnia. In fact, my own professor, Dr. V. Ramchandran, used to say, in old age, there seems to be only 2 problems. One, inability to sleep. Another is constipation. All other complaints, they don't seem to give so much importance, whereas the sleep disturbance and constipation are the 2 predominant complaints of the old age. Insomnia definitely affects old age because lack of physical activity and spending whole day in the same place or room without stimulation, all these things can lead to insomnia. And insomnia is the two-way relationship. It can be the result of depression or it can be the cause of depression. Then, of course, the functional impairment and slowly declining cognitive abilities. So you're not able to remember names, you don't remember where you kept things, and you're not able to think as fast as you could. All these things, though not signs of dementia, if it is severe, then we get into dementia, but it can give rise to depression. And again, depression itself can give rise to cognitive impairment. So, the course of adverse life events. We called it reactive depression. Now the terms have changed. But even now, I think keeping the term reactive depression is helpful in the treatment, because the focus of treatment will be on making them accept the adverse life events that has happened. If it can be changed, then focus on changing. If it cannot be changed, then accept. In fact, one of the popular speakers was talking the other day about a person who had a lot of relatives as doctors and was a rich person, was a philanthropist and all that. And his daughter died because at that time there was no help. And he couldn't come out of the depression of that. And because of that, a lot of social activities in the village stopped. So this man went and talked about an incident from Mahabharata, were Abhimanyu, who died in the war. Then he said Abhimanyu's uncle was the god Lord Krishna, then the father, and all those people who had so much of power, but in spite of that, they couldn't stop. Then this man started weeping, and he said, like, this opened my eyes. I thought that if only I have had the car, if I have taken my daughter in time to the doctor, I could have saved. But now I understand nothing could have saved her. So like that, probably the reactive depression, though the term has been removed, but that gives us an idea regarding where to focus the treatment. But at the same time, we need to understand that this can occur without depression. That's where we called it endogenous depression. That's completely biochemical in nature. Then insomnia is not only a risk factor for developing depression in older adults, but persistent insomnia has been associated with persistent depression. That's why I talked about it can be the cause, it can be the symptom, so both can be associated. So the focus of treatment changes when you get into the details of the symptoms. So the general medical illness, because it has become order of the day, gone are the days where we have seen people 80 plus with no physical illness. Now, increasing medical facilities has increased the longevity of life, but has it improved the health? We have to look into that. So if a physical illness starts, a new onset physical illness, that leads to depression. And again, the severity of the physical illness is again an indicator towards depression. And this physical illness leads to disability and restricts mobility, like rheumatoid arthritis or probably diabetes with reduced blood supply. Again, as I mentioned earlier, pain, intolerable pain, persistent pain. And then again, it's a single illness or multiple illnesses. As I said, one illness gives certain amount of disability or distress, but it is 2 or 3, then the number of medications they need to take, the restrictions they have on diet and other things, the restriction they have on the social interactions and the ability to attend parties and other things, all those things change according to the level of illness, disability associated with the illness, and whether it is one or more. So depressed mood may be the first symptom of number of medical conditions affecting older adults, including stroke, diabetes, cancer, hypothyroidism, coronary artery disease. Like, it can be the forerunner, and if you identify and treat depression, then it might work out or prevent the disease. In fact, in my Dr. JKP endowment oration, I talked about stress management is more important than cholesterol management. There I talked about depression. Surprisingly, a week after I gave that oration, depression was accepted as a risk factor, that too as at a level of 2, smoking, cholesterol, all other things were about 0.8 to 1. It is almost 2 times the risk. American Heart Association accepted depression as an official risk factor only at that time. Then even anger was considered as the reason for acute coronary syndrome. So depression, emotional issues can be affecting the individual in many ways. So if you identify depression and treat it early, you can prevent a lot of physical disorders or improve the quality of life. So what are the types of depression? Just to name a few: major depressive disorder, which the symptom lasting at least 2 weeks, that interfere with person's ability to perform daily tasks. So in fact, many people ask me, Doctor, I have depression. Is it a disease or not? How do I identify? If the depression lasts for more than 2 weeks, and if it is interfering with your productivity, if it is affecting your daily life, Without that, what you will perform is different from with that, what you are performing. Then it's depression, then it needs to be treated. Then the other entity is persistent depressive disorder for more than 2 years. But they will be performing their daily tasks, unlike someone with major depressive disorder. It may not interfere, but still the quality of life and the productivity is definitely much less than what it will be without that. Then sometimes some of the medications used to treat physical illnesses themselves can cause depression, and also alcohol and other substances that can cause depression. Then a medical condition, like I said, drugs used to treat a medical condition can produce depression. The medical condition itself can be giving rise to depression, like multiple sclerosis, heart disease, diabetes for that matter. So we need to be careful in these individuals. So a person at a late life without any physical diseases, with a good social support, then this risk for developing a depression is less, whereas the social support is less, he has got physical diseases, and it is producing disability, and it is also more than one, then he needs to be watched more carefully because his chances of developing depression is high. So what are the symptoms of depression to run through quickly? The core symptoms are persistent, sad, anxious, or empty mood, loss of interest in one's pleasurable activities, including sex, decreased energy or fatigue. The chronic fatigue, in fact, a lot of people go to the general doctor and say they are tired and end up getting vitamin injections. When they come to me, when I measure, the serum B12 levels are phenomenally high, sometimes even 20,000. What needs to be about 800 is the maximum limit. So it means that these people are going with fatigue, going to the primary care physician, where they are not identifying the depression behind the fatigue, and they start treating the physical symptom in a symptomatic way without going to the core or root of the problem. That's what I wanted to highlight by giving this example. The psychological problems are feelings of hopelessness, guilt, worthlessness, and helplessness. In fact, some time back, I was talking about perinatal depression to a group of gynecologists, where I insisted guilt. If somebody, a mother who has recently delivered a child, comes with guilt, then probably they're going through depression. So more than anything else, somebody is feeling guilty for something without reason, then that is one of the major indicators of depression, I would say. The other three are what we call the cognitive triad of hopelessness, worthlessness, and helplessness. Then they have difficulty concentrating, remembering, and making decisions. Sometimes we may take it as the norm of the old age. He's already old, so he has got difficulty concentrating. He has got difficulty remembering or making decisions. But this has to be differentiated from depression, where if he can treat, his concentration can improve, he can remember better and make better decisions. So is it a part of the depression or is it a part of the normal aging? We should be able to differentiate, because one is treatable, other is only trainable. So the other aspect is irritability and restlessness, which causes a lot of problem. Again, this can be taken as a part of old age, because he is old, he is irritable, he is restless. It's because of the age. That's what many people think. But again, if we can get into the root and see whether it's the reason depression is behind it, which can be essentially treatable. Then thoughts of death and suicide or suicide attempt is quite common. In fact, initially I thought, like old age, they will be having physical problems and they may not be thinking about suicide. But after joining here at KMCH, I have come across quite a lot of cases at 70, 75, attempted suicide and completed suicide. I see quite a lot of them. So the biological symptoms, difficulty sleeping, and early morning awakening. Normally, somebody who used to sleep at 6, wakes up at 4 or 3, unable to continue their sleep after that. That's an important symptom of depression. Oversleeping, atypical depression, let's not focus too much into it. So difficulty sleeping, more than difficulty, they're able to fall asleep, but they wake up earlier than usual time. That's an important indicator of depression. Then eating less, very rarely more, because when the anxiety is high, then they start eating more. So if there is a significant weight loss, then we need to be looking into that. Moving or talking more slowly and having trouble sitting still. That's the restlessness. So what are the challenges in the diagnosing depression in the elderly? One, the symptom complex of depression does not present like that of adults. Most elderly deny mood symptoms, but may appear fearful or sad. But when you ask them, are you depressed? They say, no, I'm not depressed. Why should I? They go into a denial or defensive mode. They don't want to accept they are depressed because they think it's a failure on their part. So that's one of the important things. Loss of interest in usual activities, but not impairing other spheres of life because already their productivity has come down, their contribution level has come down. So they may not be able to identify it quite early based on other things. And irritable and brooding behavior, as I said, and multiple body complaints may be taken as part of the normal aging and may not be given much importance or significance by the caregivers or the primary care physician. So these are the areas where we need to focus. And if we do that, we may be able to detect depression at an early age. So self-assessment, if you ask only 5 questions, like, are you basically satisfied with your life? Do you often get bored, feel helpless, prefer to stay at home rather than going out and doing new things? And do you feel pretty worthless the way you are now? So no to question 1 or yes to question 2 to 5. So 2 out of 5, even if you get that's 40% score, then probably this is an individual who need to be screened in depth for depression. So very simple, 5 questions can identify somebody need to be screened for depression in DCHI. So this is a very simple and effective tool. Again, as I highlighted, suicide in the elderly is a major risk factor. The attempts are less, but completed suicide are more. That's where we need to be very, very careful. An elderly person attempts suicide, it's always with an intent to die. Whereas an younger one, sometimes it may be an attention-seeking suicidal attempt. So acute risk indicators for suicide are insomnia, and if they're feeling hopeless, agitation or restless, impaired concentration, then of course substance use and pain, as we have been repeatedly emphasizing, a pain which is chronic, which cannot be treated, is always a danger sign. Other risk factors, of course, the physical illness, pain, terminal illness or worsening physical illness, and they themselves lose hope. What's the point in me continuing to suffer like this? Where in older days we used to have a term called justifiable depression, the condition through which they are going through. If they don't get depressed, then only it's a surprise. Then, of course, widowhood, social isolation, prior suicidal attempt, and if there is a family history of suicide, then we need to be careful with these individuals. So an untreated depression in late life can lead to dementia. The risk of all-cause dementia was increased 70% in subjects who had late life depressive symptoms, and that's why we plan to have depression as the first part of the discussion, and dementia will be taken care of by Dr. Selvaraj. So what are the treatment methods? As I said, psychotherapy is effective, but in severe, moderate to severe depression, we need pharmacotherapy. So we need to identify. But once we identify the treatment, a monotherapy is better than a combination of drugs. and use minimum drugs as far as possible. Single tablet, to be more specific, is better. And also single medication is preferable to prefer because they are already on multiple drugs, so drug-drug interaction should be avoided. Dosage again should be adjusted to the minimum. And again, somebody with hypertension, and if you are using an antidepressant, then we should be looking for sodium is one of the important things which may cause problem. A low sodium when we start the treatment on antidepressants, who is already a hypertensive, taking a salt-restricted diet, that's a very, very dangerous combination. So by starting the treatment for depression, we should not precipitate an emergency. That should be very, very careful. So psychotherapy can help the person identify and also work on the emotion, thoughts, and behavior. It may be done by psychologists, licensed social workers, psychiatrists, or other mental health care professionals. Two of the common therapies are CBT and interpersonal therapy, but most of the time we use a combination of all these things and call it eclectic form of psychotherapy. So medications typically take about 4 to 6 weeks to show efficacy. Full antidepressant effect may not occur up to 12 or 16 weeks. That's why invariably I tell all my patients it takes about 3 to 4 months for you to get a proper improvement. Like fever or headache, if you're going to expect the result within a day or two, no, this is not the thing. And we also need to tell them in advance that long-term treatment may be necessary to prevent recurrence. So patients should be contacted or seen within 2 weeks of initiating medication to discuss tolerance and adjust dose as indicated, because in old age we need to be all the more careful. And then we need to plan frequent visits to monitor for side effects, any complications, or after starting the medicine, if it is deteriorating, then we are missing something else. So a lot of things are very, very important in old age, whereas an adult 20, 25, the treatment of depression may be relatively easier, but in senior citizens, it requires a lot of attention into the specifics and nuances. So home-based interventions for mildly depressed older patients with limited mobility or care may be helpful. The availability of home-based intervention is limited. So the active treatment administered by social workers and included referrals for medical and social services, education about depression and stress reduction, and behavioral activation. That's another thing. A lot of people with depression come and say that they just lie all the time, even if they don't get sleep and they are not able to do anything. So we need to guide them to be active, to do whatever they can, whatever they are interested, because that in turn has an effect on depression and that relieves depression. So behavioral activation is an important thing. Home-based, it can be done and it's cost-effective, but a little difficult in the initial stages for people to accept, but definitely it's a very, very useful treatment, behavioral activation. So remission of symptoms occurred in more patients in the intervention group than in the placebo group, just to tell you that treatment of depression is effective, and just leaving it does not resolve the depression, except the milder ones or the reactive ones, where the initial adverse event has changed, then the depression can resolve by itself. That doesn't mean that you can leave all the individuals with depression without treatment. So what are the summary? Identify symptoms of depression and other abnormalities in mood, improve exercise and mobility, consult a psychiatrist if functioning is impaired, to maintain routine sleep and feeding activities, to socially integrate in family settings, and do adequate screening using the 5-item questionnaire, to take care of other medical conditions and disability. So in conclusion, I would say that depression in the elderly is different from depression in the regular adults. Elderly have a higher chance of getting depression and they require longer treatment and associated physical illness, their functional impairment, and the pain may lead to depression and sometimes suicide. So we can improve the quality of life as well as prevent a death if we identify depression at an early stage and treat it appropriately. Thank you very much. If you have any questions, put it on the chat box and we will answer all the questions together towards the end. Now it's over to Dr. Selvaraj for his presentation on dementia. Thank you, Dr. Selvaraj and Valigatti for all the arrangements. Wonderful once again.
Thank you, sir. Very good morning to the participants. Let me share the screen. I hope my slides are visible.
Yes, sir. Full
Yeah, my voice is also heard, I suppose.
Yeah.
Okay. Yes, I appreciate the audience for taking the time of holiday. We are addressing two important areas of concern in elderly. One is depression and dementia. With the limited time, I will quickly go through about dementia. Then at the end, we may have some questions. So dementia is a very general term. Basically, it is a mental state which is abnormal in elderly people. And its characteristic is memory impairment. And that is how most of the people know about dementia. But it is not just memory. It interferes with their thinking process, reasoning process, and interferes with their judgment as well. So a dementia interferes with the effective functioning of the individual, and when it is severe, the personal life of that individual is greatly affected. Any impairment in memory, reasoning, and judgment will be called as dementia only when it is severe enough to interfere with the person's independence and daily activities. Well, dementia may mean different things to different people. Alzheimer's Disease International has given a list of 10 symptoms and signs which will denote dementia in elderly people. We will just quickly look at those important 10 symptoms and then we proceed further. Yeah, the single most important characteristic of dementia is memory loss. Many people equate memory loss with dementia. Dementia means loss of memory. This memory loss in the early stages very prominent for recent events. What happened yesterday? What did he take for breakfast? Who visited them yesterday? And those kind of things. An hour back, somebody might have said something they would have forgotten. So that is the important characteristic of early dementia. That is difficulty for recent memory impairment, whereas in the early stages, long-term memory is intact, where they studied what happened during their childhood, all those that marriage-related early period is very well remembered. But day before yesterday, what happened, they may not remember. That's a very important characteristic of memory loss. Then, when the dementia is beginning, they have forming the familiar task. A person who is working in office, who has been doing the work effectively, this person who is in 60 plus suddenly is finding it very difficult and started making mistakes. Housewife who has been cooking and managing all the household suddenly finds it very challenging. Even sambar doesn't come the way she used to make in a tasty manner and missing things. Those are all the things can be early indicators. People having dementia have difficulty with language. They find it difficult to name certain objects, and sometimes they want to communicate something. The names do not come up quickly, and they may recognize the person, but they may not be able to tell the name, which is a common experience, even in normal, but in a very mild level happens. In dementia, it becomes very significant. And also they may get disoriented. They may not know the familiar place itself. Though these things happen, the stages, the time disorientation, whether it is morning or evening, the hour of the day, there can be problems in the dementia. Well, apart from memory disturbance, the reasoning process also gets affected, because of which they are not able to interact properly and take proper decisions, and the judgment is impaired. Sometimes they may even take a financial decision which is very, very inappropriate. So the overall reasoning ability is getting affected in dementia. And the problem keeping track of things, and what happened a couple of days back, what they need to do. Frequently they miss the appointments, the engagements. They have to go to a particular marriage or function. They don't remember it, and they come to know only later about it. And this is very, very common problem in dementia, misplacing things. The keys are misplaced, spectacles are misplaced, and their own dress gets misplaced. So searching for it has become a very important activity, and that creates difficulties in the family as well. And change in mood is another aspect of dementia. They become suddenly fearful, they can be irritable, or sometimes they can be without no reason, they can look very joyful as well. So the fluctuating mood, instability of mood and related behavior is an aspect of dementia. And some people, the early onset of dementia can manifest in visual areas. They may have difficulty in figuring out the signals, some understanding the space. So there can be confusion. Sometimes they may find it difficult to get back to their own home. They might miss the street. These are all the features of dementia. And as the difficulties increase, they withdraw from the work and social activities. They stop talking to people and try to isolate themselves, which further reduces the quality of their life. Well, why all this happened? This is because of the changes in the brain. You can see that the healthy brain, how it looks, and the Alzheimer's disease, how it is shrunk, and this manifests as a diminished capacity of their mental functioning. As I said, dementia is a general term. It is a description of the signs and symptoms of the mental condition, but it is caused by some specific disorders like Alzheimer's disease and blood vessels getting affected, blocked, and there are some degenerative disorders involving certain parts of the brain like frontal lobe and temporal lobe, and some condition called basal ganglia degeneration. All these can contribute to dementia. And among the various causes for dementia, Alzheimer's disease is the most commonest cause for dementia, which accounts for 60 to 70% of all dementias. Just As an example of dementia, we will be looking at Alzheimer's disease, which is the most common cause for dementia, which accounts for 60 to 70%. It is a neurodegenerative disorder. The true cause of Alzheimer's disease is not ascertained. Though we have some understanding about pathogenesis, we do not know what initiates those kind of pathology. There is a abnormal protein accumulating in the brain cells and causes the death of those neurons and eventually causing the dementia like clinical condition. Well, it is important to get an idea of the course of the dementia or in Alzheimer's disease. The early changes are very gradual and very subtle. It may not be even noticed by the family members. But the first and foremost difficulty is recalling the recent event and recent information, because of which they tend to talk the same thing and again. They go to a relative's place, come back and talk something about it. Then they forget they told about that. Then they again talk about it. So they forgot that they communicated. Sometimes they forget the whole visit, and even when asked, they don't remember precisely. And suppose they want something, they ask for it, and saying that no, I want to go to market, so I want lift. So they tell the family member. Again, after 10 minutes, again they repeat the same thing, and because of that memory disturbance. So that forgetfulness is the first indicator of dementia onset. Of course, other difficulties are impairment in naming difficulties. There, they may be having difficulties in concentration and thinking clearly, and complex tasks like cooking and finance management. All those things will become difficult as the illness worsens. Sometimes, as the early stages moves into mid stages, they may find it difficulty in traveling in familiar places. Of course, late stages, their functioning becomes very difficult, able to communicate effectively and take decisions, and even taking care of themselves will become very difficult, and they become dependent on the family members. Apart from the decline in the mental ability, and there are other problems that happens alongside in dementia, which causes a lot of difficulties. They can become angry suddenly. Sometimes they can become agitated. Sometimes they even become depressed, which we are not able to understand. There will be sleep disturbance. They not only sleep, the others also are disturbed because of their sleeplessness. Sometimes they imagine things, they suspect, they see images which are not there, they get disoriented, and sometimes in the end stage of Alzheimer's dementia, even eating, bathing and dressing becomes difficult. At the terminal stage, they are not able to control the bladder and bowel. So they become so demented. And this kind of dementia after the onset can reach a severe stage in 5 years. For some people, it may take even 10 years. Eventually, they die because of intercurrent infection like pneumonia or bladder infection. Sometimes because of their frailty, they fall, and then eventually they die of that kind of complications. And the prevalence of dementia. Now, the elderly population, that is aged about 65 is about 14 crores, that is the estimate, of which about 1 0.5 to 2.7% is supposed to have dementia. I mean, in a way, about 1 crore people can be having difficulties with dementia in about 140 crore people of India. And the dementia becomes more common when the persons become older. Now the people above 80 years suffer from dementia. And the mean age of dementia presentation is 66 years. By definition, elderly from the health point of view is 65 years and above. Though in India, senior citizens are classified as 60 years and above. Well, the age is the single most important risk factor dementia. And after 60 years, the risk of dementia goes up. 1 in 6 people between the 80 to 85 years are having dementia. And after 85 years, 1 in 3 may be having dementia. Over 90 years, half of the people have problem with the dementia. Another important risk factor is the family history of dementia in the family members, particularly when they develop dementia less than 70 years of old, the risk is high. But when they develop over 75, 80 years, the family heritability is less. Other non-risk factors are diabetes, blood pressure, smoking, and sedentary lifestyle. These are all enhances the risk, though it is not directly connected with the development of dementia. Well, one of our major concern is about whether our memory disturbance in old age is always dementia. All of us will have some difficulties with the memory when we age. It is related to aging, but those difficulties will be minor difficulties, and that is more to do with what immediate memory rather than recent memory or long-term memory. They do not worsen over time like that of Alzheimer's disease. It does not interfere with the person's day-to-day functioning. So there is a clear distinction between the normal dementia-related memory decline. And the dementia can start with mild cognitive impairment. They also present with memory difficulty. It can interfere with work or home functioning. And this, just like MMSE and MOCA and clinical dementia rating scores, these are all the psychological tests which can be used. And this cognitive impairment can progress over time. For some people, it can remain the same. Only the time will be able to tell which way this goes. So, in a simple algorithm, there is a memory disturbance, but no functional improvement. Psychological test, there is the tests are normal, which will be called as normal aging. Whereas there is a functional impairment, and that is only in a limited minor functional impairment, but tests are positive for memory loss, then it is called as mild cognitive impairment. When the impairment is severe along with the memory loss, and the tests are also positive, we call it as dementia. So in any patient, when they report memory disturbance, whether it can be a normal memory decline of due to aging, or it can be mild cognitive impairment, or it can be a full-blown dementia. Well, once the diagnosis of dementia is made, treatment. Drugs are there to treat Alzheimer's disease, but they have a limited use. They do not reverse the underlying disease. They do not make any great changes in their memory. So they have of very limited use. like donepezil and memantine are used by doctors, psychiatrists, and neurologists, but we are yet to find a drug which can cure or prevent dementia. But the problem with dementia is not only memory loss, the associated behavioral problems, and they can cause more trouble than the plain memory loss. Well, those kind of behavioral symptoms are agitation, irritability, anxiety, even psychosis manifesting as hallucination and delusions. Drugs like antipsychotics and antidepressants and anti-anxiety drugs are used by psychiatrists to control these kind of behavioral symptoms and improve sleep quality. And there are a lot of non-pharmacological treatment can be done in patients with dementia, that is attending to her food and nutrition and brain training, which is what we call as cognitive rehabilitation, exercise programs, and occupational therapy is a very important activity-based help, which is helpful in dementia. And there are other important issues which requires pharmacological management, their capacity to take decision regarding their finances, writing their will, whether they are capable of driving, and their safety. They may wander away and get lost. They may fall and break their bones. All these things are possible. Well, caring for a dementia patient is an enormous burden, and particularly dementia becomes severe, patients may not be able to care for themselves. It becomes the responsibility of the caregivers. Caregivers almost have to live their day on a day-to-day basis, and every day it will handle the patient, and they should be extremely flexible to unforeseen developments in the day of the patient. The most important requirement of caregiver is being patient, because the patient can ask questions. In spite of the repeated advice, they will continue to indulge in the same behavior, which will test the patience of the caregivers. That is a precious trait the caregiver needs to possess. Well, few of the common tips for caregivers is not argue with the dementia patient when they are wrong. That is not going to improve the matters. And when they are expressing wrong ideas, we should change the subject. After some time they may forget those areas. Using memory aids can be very helpful, having calendars and having a board and instruction, and even in bathroom, toilet. All these things will be dementia patients. The night is a very challenging time for dementia patients, where they get into confusions, and it is generally recommended leaving when the patients are sleeping in the bedroom, because without light they may get into more confusion. And the living environment should be consistent, and there should be a lot of safety measures, and the drugs should be locked, because they may forget they have taken drugs, they may take again, and they may misuse electrical appliances. Even bathroom usage become challenging, and they may find it difficult to even take care of their personal needs, even urination and using their dentures. And when we talk to them, we have to talk slowly, and encouraging them to do physical activity and exercise is very helpful. Respite care is something very important concept. The caregiver burden and the burnout is very common in families. Daycare facilities where available, patient can be sent along with the attender, and sometimes the patients can be kept in respite care homes, where the family can take a break for a week or two. So respite care is an important option. and the family members can be part of the support group where the fellow group members understand the troubles the family with dementia is having. Well, I'll be running through it. Treatment of behavioral symptoms is the most critical element in caring for dementia, and a lot of medications are available that can be used. Well, this is one important point. How long these persons are going to live. It is about 10 years or 8 to 10 years the persons can have after the onset of dementia. When they have dementia in the younger age, I mean younger age in the sense in the 60s and 70s, they live longer. But if they develop dementia after 80, they live for a short time. So the onset of dementia is critical in deciding the longevity of the dementia patients. There are studies related to that. Well, a dementia patient is a big challenge for the family, and the disability of that elderly person can become the family. However, it need not go that way. A lot can be done to support the families and help the patients with dementia. So that completes my presentation, and we can go ahead with question and answer sessions. Stop sharing. Yes, sir. So, questions which have come in, or we can ask for participant to directly communicate with regard to questions, and they can type in the chat box as well. Dr. Srinivasan, you want to add more? We can please proceed.
No, I think there are no questions in the chat box, so anybody wants, they can raise their hand, and then probably the administrator can unmute them and ask.
They can unmute and ask questions.
And if there are no questions, then we will conclude.
Trying to ask questions, but I don't know that they have unmute.
I think there are no questions and
Yeah.
presentations.
So probably I will say a few words about ARDSI.
Yes. You
Yeah. This Alzheimer's and Related Disorders Society of India is a national NGO, and that is committed to the welfare of patients with dementia and supporting their families. They create awareness and they try to provide services. And we have a chapter in Coimbatore of this ARDSI, and we are trying to increase awareness about dementia and try to provide services. So there is a Facebook page, and people can contact us for any help relating to dementia care. And there is one question: is dementia transmitted through the genetics? Yes, and that is one of the risk factors. And to what level of heritability is still not certain. But if the family member has developed dementia when they were in 60s or even 50s, the chance of transmissibility is high. When the dementia happens in the family members after 70 years, 80 years, or 90 years, the transmissibility is through genetics is less. So that is the current understanding. Presence of grandchildren, does it have an impact on elderly? Definitely, whether somebody is demented or not, having grandchildren is a boon to the elderly, because the elderly persons, their own adult children are engrossed in their life, and many times it is the grandchildren create meaning to the elderly people. Sometimes they lack family members to live with them. Even pet therapy has been encouraged. Having a pet dog can make a lot of difference to patients and elderly people. And
Something
yeah,
quality.
yeah, Srinivasan, somebody is talking about a spiritual way of treatment. You can see in the chat box and respond.
Spirituality, probably meditation, yoga, that kind of thing definitely helps, and also finding a purpose and meaning in life, that also helps. So spirituality definitely helps in preventing depression, at least. Dementia, yes, probably the breathing practices and other things, and yoga, definitely when you practice on a regular basis, that also helps prevent or postpone dementia.
Okay, one more question. As people having memory issues in younger or middle age is vulnerable to dementia? May not be. I mean, memory disturbance is a very frequent issue in anxiety disorders. Students becoming anxious during examination time in Viva OC, oral examination. They don't remember things which they know very well because of anxiety. So most of the time, this degenerative disorder related memory impairment occurs in old age after 60, 65. In the middle age, if there is happening, we have to look for causes like anxiety, depression, and even depression in elderly is also called as pseudo dementia, because they can present with memory disturbance, but the underlying cause is not dementia, but it is depression. And that is why sometimes it is called pseudo dementia. So it need not be a risk factor for dementia.
I think we can conclude.
Yes, sir.
We had a fairly good discussion and good topics, and we communicated well. So we can do the concluding remarks.
So I thank the participants for being here. It is not a very fancy topic. It may not be immediately relevant to many people, but the enthusiasm to know something about this condition is highly appreciated. We thank all the audience and participants for being here on a holiday. Thank you very much, and very good day to you all.
Thank you.